Okay, I'm very, very pleased to be here. This is my very first time giving lectures for like 30 people. I'm filling in for Dr. Potenza. I just told him, if I can help him from 2,000 of things that he have to do, I'm really happy to do it. So, okay, so the topic for today, Dr. Potenza and I agree, to present a smoke and chemical inhalation injury. So I'm just going to overview it, and then we have case study toward the end. Let's just make it, more sense how you utilize, the information into this case study. All right. So people know me as NP5, but this is the whole thing, okay? So don't try to remember. You never get me. So, okay. The objective, I would like the audience in here have, ability, to know about what is a toxic element in a house in a structural fire, and also to provide a significant statistic incidence of the smoke and chemical injury that happens. Also, I just want to present some overview of pathophysiologies and the current management that we have available right now for the treatment option of the smoke and chemical inhalation injury. Okay. And let's start with introduction here. Definition-wise, smoke inhalation injury is defined, as inhalation of the chemical irritant, and also the incidence of inhalation injury in the United States, believe me or not, is more than 23,000 injuries per year, and 5,000 to 10,000 deaths per year for the inhalation injury alone. Smoke toxicity is increasing, in the number of the injury, because nowadays the product that used, in the house or in the structural, industrial-wise, is shifted from the wood, from the natural material, toward the lighter construction materials, such as synthetic and petrochemicals. Which all these petrochemical and the synthetic material, they ignited 2 or 3 times hotter and faster than the natural material. That's why the victim, were trapped, have less time to escape. That makes the worsening of the exposures. And this is a little bit of example, all of you in here, would be a first responder, with the disaster, which is, can happen anytime, any days. So this is a structural disaster that some people remember is a major disaster of the Station nightclub fire in Rhode Island, 2005. So going to the nightclub can be very dangerous, okay? Just stay home and drink. All right, and of course, we never forget this, the terrorism attack, on the Pentagon in Washington, D.C., 2001. And interestingly, people, have a lot of injury also, in the World Trade Centers that was attacked in the same year, 2001. And among 790 injured survivors from the World Trade Center attack, they follow up the case. 49% of 790 survivors still suffer from the inhalation injury that's caused by the toxic compounds in the smoke and the dust alone. And of course, let's get in closer here. The house fire, every of you never forget this. Right, in year 2003, Cedar Fire, and the Harris Fire in year 2007. Of course, October of every year, it raises our awareness. Like last meeting, with the burn leader meeting, we already discussed about, how we're going to prepare for this. Of course, my commander, Dr. Potenza, is on top of it. Okay, let's see some example here, about the toxic element in a house and structural fire smoke. Carbon monoxide, carbon dioxide, and nitrogen dioxide, is the source why is coming from burning of organic material like wallpaper or wood, is cause the patient to have a tissue hypoxia, tissue necrosis, bronchial irritation, dizziness, and pulmonary edema. And other exposures that we have the risk of exposure of this are hydrogen chloride, phosgene, or hydrogen cyanide. The source is coming from burning wool, silk, cotton, plastic, nylon, and those affecting the patient to have can go into coma, respiratory depressions, and also cardiovascular collapse and severe mucosal irritation. In these situations, you may have get some of the patients that have MVA accident and they were trapped in the car. Remember the car seat is some of them is still nylon, and then they couldn't escape it soon enough. They can easily get cyanide poisoning from that. And then also the exposure to the benzene is from petroleum, plastic, glue, paint, and furniture wax. This could be like occupational exposure as well. It may not be like happen this all at once, and some of the workers are exposed to them like over a period of time until they develop this symptom like drowsiness, dizziness, rapid heart rate, headache, confusion, and in the severe case can cause the unconsciousness. Also, the last of the toxic element that I like to mention is the ammonia, which is from pesticides, leather, freon, rubber, plastic, and nylon. The side effect wise, the patient can come in with severe mucosal damage and also can cause mucosal irritation and can cause extensive lung damage. Okay, let's overview with pathophysiology wise, of the inhalation injury that can occur in 3 ways. In the cellular level, and the pulmonary parenchymal damage by the irritants directly damage the lung. That's what it means. And also the hypoxemia is caused by the interruption of oxygen delivery by the asphyxiant. And also the systemic toxicity, that's the worst case scenario. It causes in organ damage by systemic absorption through the respiratory tract. Okay, so as a result of the thermal injury, because sometimes the patient will be trapped in the car, it's not the inhalation injury alone. Also the heat that they inhale, is causing thermal injury to the respiratory tract directly, or it can go directly to the lungs. And the secondary insults, of course, when the patient is intubated and stay in ICU for a little while, the is insulting in bacterial pneumonia that occurs several days after the injury. And therefore, the inflammatory cascade, that's initiating the neutrophil infiltration, and the macrophage in the alveoli are destroyed and allow the bacteria to proliferate even faster. And the lack of the intact epithelial barrier, is cause of further facilitate of the bacteria, and the patient develop serious pneumonias. And the hypoxemia is results from the decreased oxygen inspiration on the scene of inhalation injury, and also the cause is caused by a mechanical inability to gas exchange due to the airway obstructions, and also impaired impair oxygen delivery, and the tissue cannot utilize the oxygen because it was blocking by carbon monoxide or cyanide alone. And multi-organ dysfunction is a common sequela by the hypoxemia, which increase the morbidity and mortality in the inhalation injury. Systemic toxicity, I just strongly want to be emphasized about carbon monoxide, which is we see a lot that came in the trauma bay. Carbon monoxide alone, is actually not directly injure the lung, but the toxic effect, from the displacement of oxygen from the hemoglobin binding site is compete the hemoglobin to bind the oxygen, which they have like 254 affinities. That's why, you will have a lot of oxygen that floating around, and could not be utilized because of this reason. Some of my CCRN students, always study about this. Oxyhemoglobin dissociation curve is going to shift into the left. That's how you see mixed venous O2 sat, is really high. It's like 75, 90. It doesn't mean like, oh, you have adequate oxygen. In fact, you have oxygen that's floating around, but your body cannot utilize it. And also importantly, carbon monoxide, also react to myoglobin and causing further impair of oxygen reuptake and decrease the diffusion to facilitate oxygen into the muscle. The muscle that have a lot of myoglobin and need to use oxygen, in a tremendous amount is actually in our cardiac muscle. That some of them can just easily come in here with cardiac arrest. Okay, also, I like to emphasize about cyanide. Cyanide is actually cause the tissue hypoxia by its inhibited intracellular cytochrome oxidase. Is in the mitochondria level. And then when the mitochondria cannot use the oxygen, they start to working out by becoming an anaerobic process. That's how it's released the lactic acid. So that's why you can see that we have to check the lactate in some of these patients that come into the trauma bay in this sense. So we'll identify how bad the tissue hypoxia of the patient is. And also remember, our brain and our heart is a very sensitive organ for the oxygen deprivations. In only 3 minutes, the brain cells start to die off. That's how important, to make sure the patient gets 100% oxygen. We're not looking at the O2 sat. We're looking the whole picture inside the cellular level. And therefore, when the patient was trapped in the car, imagine when the brain, doesn't have a lot of oxygen. What do? Any of us would be like hyperventilating, right? In order to blow out this carbon dioxide. But when they're trapped in the car, when they're hyperventilated, they inhale more of the cyanide and carbon monoxide. It the worst case scenario in that sense. Okay, this is a little bit of pathology level that shows the small airway injury from the smoke. You can see this is a bronchoconstriction that's caused by mucosal injury. And this is a pathology report. Is fetal smoke inhalation injury. And you can see this airway and alveolus collapse with the massive. Did you see this dark spot here? This is a massive atelectasis. And this is the trachea. Okay, you can see it's casted with the mucosal cast. When the tissue is hypoxic enough, it makes that pale looking pictures. And also this is cross section, the closer view of mucosal slough. That's found in the massive inhalation injury. And the mucosal plug is a common finding in a significant smoke inhalation. Okay, the symptoms wise, mostly the patient came in, they come in talking, just look like nothing happened. And they always want to go home. You know that. They're signing AMA, give me any paper, I get out here. That's how it is. And therefore, the early symptom, it can be like bronchospasm, wheezing, have excessive mucus, and can have intense mucus, it's caused by the irritation of, by the irritation of the airway mucosa in a combination with the increased oral and nasal secretion. Also, it can cause it look like the patient have like a fulminant pulmonary edema. They're constantly coughing and coughing. But you have to really be careful. Pulmonary edema in the lung injury with inhalation injury is non-cardiogenic. Tell your internal resident, can you just please not try to diurese the patient, okay? It just look like, it just sounds like, but it's not something that I like. Okay, of course, as we always ask you, did you see anything in their mouth? And some of you will say, yeah, there is a soot, you know. And the soot, you know, in the lung secretion is mostly evident by the smoke inhalation, but sometimes it's not always fighting right away, you know, until they start to cough and try to bring something out. That's how you say, that's how I always ask, when they cough, can you just say that, what he coughing out? That is helping me more in that sense. And also have symptom of bronchospasm and bronchiolar edema is initiated by irritant gases that cause decreasing lung compliance and increased work of breathing. We talk a lot about VQ mismatch. You know, it's just a good review on a lot of you who is a critical care nurse. So VQ mismatch is create impaired gas exchange with increasing of alveolar arterial gradient and increasing in the minute ventilation. Let's go to the few definition here. This might make more sense. Okay, so VQ ratio, what is telling you? The ventilation and perfusion ratio is a relationship between two variables. Okay, the ventilation ratio is really telling you about the amount of air that reaching alveoli, and the perfusion ratio is telling us about the amount of blood that reaching the alveoli. So these two have to work hand in hand in concert. So when you're talking about there is like area of no ventilation, that's how we call the pulmonary shunting. You heard it many times. This is what it means. And also in the area of no perfusion, its term is dead space. Okay, what is the diagnostic test that can be done quickly? Of course, we always asking you guys, okay, can you just check the ABJ and make sure you have a check box for the carboxyhemoglobin as well. That's always. And of course, just the quick look, you can just have the laryngoscope, and just looking into the mouth, and you can see any demonstration of the mucosal irritation above the cord. That is just a quick look one. But of course, the gold standard is still be fiber optic bronchoscopy. This is, you can call the pulmonary fellow, the bronch fellow, to come and bronch the patient in the trauma bay, like ASAP. At the time that housekeepers still clean the room in burn unit, you can do something else that's fun. Okay? All right. The chest X-ray, what it's telling you, most of them come in, they look fabulous, right? It's like, doesn't look like anything wrong. It showed really nothing in early injury. And then when the debris start to go down deeper and the airway edema start to develop, and the bacteria trapping on the debris, and now the patient have infection, and later on you can see the pneumonia, and again, non-cardiogenic pulmonary edema. So when you see the film, you can tell resident, this is a non-cardiogenic pulmonary edema, okay? All right. The history of confinement, I think is very interesting. So importantly, you have to know is this the scene, right? The patient in open space or the closed space. What is this? How important to know that? The closed space during burning process is a good indicator of the potential more of severe lung damage than the open space. And also an absence of the history by transferring medical personnel. How often this happens? Almost every time. So sometimes you can find a true story 2 hours later, or it could be days later or ever. Those type of thing. I have the patient that, they call me and say, can this patient come to the clinic? Because, he's have his hand burned from the firecracker. I said, firecracker, oh, bring them in. It turned out to be is a rocket backfire. You can see the difference, this size and that. So I just said like, okay, that's very challenged. I remember him just got like 10 milligram of dilaudid and he's still screaming in the hallway. So. Okay, the key of the managing of inhalation injury always going to be the airway management and pulmonary support. Okay, suggestively, to prevent the airway closures. When you said, oh, we have to intubate these patients, you are very proactive, nurse. Just hand them the ET tube number 7 and above. 7 and 8, never go below. because the times go by, with this injury, the patient develop more thick secretion. The ET2 number 6, 6.5, it can just easily close up. And during the time that fluid resuscitations go by, the airway starts to narrower and narrower and narrower. So that's why just be generous. Go with 7.0 or 8.0. And also with the facial edema, that also can develop later, 2 or 3 days later also. And remind the RT, you're the boss, right, when you're in a trauma bay. Hey, RT, you make sure the patient, having enough humidifier, okay? Yeah, because the dry cough with the thick mucus plug, that won't help. Of course, when they hook up, they intubated, they will hook up, they're on ventilator, there's, we use a lot of PEEP, and us, we do the APRV mode in the burn unit. So the P high actually is the PEEP. So we can crank it up, start from 22, and if there's still hypoxic, we still increase it, up until like 32, if we have to. And also be careful, monitor fluid resuscitation, okay? This is the relationship between two devils. If you under-resuscitated, you will have lack of tissue perfusion. Again, if we over-resuscitated, now we're gonna go into the problem that increase the microvascular pressures and also leading into the increasing edema formation. And some of you very proactive, we just ask, can I have the, monitor the bladder pressure? I never say no. Just say, oh yeah, sure, go for it. I agree, Okay. And then, bronchial toilet. In the burn unit, we bronch the patient that have inhalation injury daily. Not just only to clean up the secretion, to visualize the airway, and to evaluate the edema. In the severe damage of the airway, you can see is turned pale looking color. That patient is no doubt, they're gonna need to be tracked. And also bronchoscopy is helping out too. In any difficulty airway, extubate the patient under the bronch is really helpful because at the time that they're backing off their scope, when they see the airway start to close up, they just shuffle it back in. So you'll be done for that day. Okay, we don't mess around, okay? Just request for one, they'll do it. So, and also prophylactic antibiotic administration. It's very controversial, but some people believe, not recommended because we're gonna develop the resistant organism. And some people say, well, when the patient, they're unconscious, they down, they aspirate anyway, just do it. So yes or no, it's just, I don't have the direct answer. But of course, if the cultures come back positive, they're gonna need antibiotic, that for sure. Okay, nebulizer treatment, when you start to have bronchospasm, like COPD, there's smoke with oxygen on, we see it like thousands of years of those patients, and they came in panic, bronchospasm, just, go ahead and grab one of those albuterol, and have the RTs manage the airway in that sense. Some of them just get settled by just albuterol and Atrovent alone. Okay, let's do some case study in here, okay? Anybody in here a trauma nurse, so you're welcome to participating in and lead the show, that's what you're here for. Okay, 32 years old male with 40% TBSA flame burn onto face, neck, anterior and posterior torso was brought in by paramedic on Friday night. And he not listening, he go to the nightclub that night. So, from the nightclub fire, okay? History of asthma, otherwise healthy. Okay, so is anyone can tell me what is the primary survey? Airway, A, we got A. What is the B? Yes, and circulation is C. I give away this one. What's about D? I heard some whisper, disability, just check neural status. What's about E? That's right. What's about that? F? Family also part of that. And this burn itself, what is about? a good one. It's a good word. So it's fluid resuscitation. So, okay. All right then. So we go over this, okay? And now he's awake, alert, like, but still poor historian. We don't know if he's drunk or he's just was trapped in there, you know, and very agitated, try to pull the IV, you know, and he say, I'm gonna leave. I have to leave, you know, I don't like to be in here. And you have him on 4-point restraint, okay? And still try to bite you sometimes. Okay, the blood pressure wise is like 130/85, respiration rate 42, heart rate 120. His O2 sat 92%, you know, with non-liberating mass. What is the secondary survey now? Secondary survey, anything? He's still talking. So of course we have to know, yeah, history, past medical history, any medication you're taking, you know, and what else? I'm sorry? Allergy, those kind of things, okay? That's right, contact number. Okay, this is the Parkland formula, okay? Somebody asked me to review this with you. The Parkland formula is the 4 ml, you know, and you times it with percent TBSA and times with the weight in kilograms, right? So we plug in this number, 4 ml times TBSA is 40%, correct? And we time it by the patient weight is 100 kilograms. So and now it's total fluid that we're supposed to give it to this patient is this much. It's this much, okay? And 16,000 ml, and we give first half of total fluid in the first 8 hours. Follow me here. And then what the fluid rate going to be? The first half is 8,000, and then you divide it by 8, so it's make 1,000 ml per hour. So if you have one good IV, you know, it's good, but try to get another one, okay? So just in case it, you know, one is went down, you will not short on time on do resuscitations. And also, we'll give the second half in the next 16 hours. So the infusion rate going to be 8,000 ml and divided by 16, and now we down to 500 ml per hour. It's an easy math, right? It's simple math. Okay, 2 hours later, he's very quiet. He's not talking. And you say, wow, he's so behaved. And the next thing you open his mouth, that's how his tongue looked like, okay? And then he became unresponsive. So now, okay, this is his vital signs now. How would you like to do then? Airway, that's right. Call somebody to intubate this patient, correct? And now he's wheezing. He have the stridor. Hurry up, you can't see anything. Okay, now it's time for you to call attending. Okay, we have to do immersion track. Okay, don't multiple attempt. The more intubation, the more make it worse in the airway. All right, we don't buy time here. So just tell them, you know, you can't intubate the patient, okay? Can I call, I'm gonna call the attending. It's time to do the track. Here's the tray, and this is the track number 7.08. Go for it. Remember in Trauma Bay, you run the show. Of course, the successful is coming from cohesiveness of the team. Never forget that. Okay, any questions for me? I try to make it short.